right. Welcome, everybody, and thank you so much for joining us on this beautiful spring day. We really appreciate it. Um, I'm Adam Levine. I'm Associate Dean for Global Health Equity here at the Warren Alpert Medical School at Brown University. And this is our Global Health Grand Rounds, where we bring one of our amazing global health faculty from Brown in collaboration with one of their international collaborators to talk about the incredible work that they're doing together. Um, as always, before we begin, I do want to thank our funders. The Paul J. Galkin Global Health Grand Rounds lecture series was endowed by Mr. Arnold Galkin in honor of his son, Paul Galkin, who had died of a rapidly advancing malignancy. Mr. Galkin has been a generous patron of both the Miriam Hospital and Brown University and wanted to establish this lecture to honor his son, who had been an accomplished young man, a patron of the local arts, and a pioneer in modern architectural design. So thank you, as always, to our sponsors. I'm really thrilled to welcome two incredible scientists, researchers, clinicians, and human beings to speak with us today. So I'll briefly introduce both of them. Before I do so, I do want to remind all of the bright residents in the room and the Going Global preclinical elective students in the room to please sign in using the QR code on that sign over there so that you can get credit for attendance today at our Global Health Grand Rounds. So first, I want to welcome Dr. C.C. Lee, whose research focuses on global perinatal epidemiology and the design and evaluation of interventions to reduce the major causes of maternal and neonatal morbidity and mortality. Dr. Lee studied biomedical engineering and the fine arts at Duke University. She received her MD from Harvard Medical School and completed pediatric residency at Boston Children's Hospital and Boston Medical Center. Dr. Lee was a primary care pediatrician at Boston Medical Center and in Boston's Chinatown at the Floating Hospital with a focus on immigrant and refugee health. After working with the Sermang Foundation to develop a maternal child health program in Tibet, she completed an MPH and postdoctoral fellowship at Johns Hopkins Bloomberg School of Public Health. Dr. Lee has served on the Child Health Epidemiology Reference Group and the National Institute of Child Health and Human Development Strategic Planning Working Group. She cares for mothers and newborns who deliver at Brigham and Women's Hospital and here as well at Women and Infants Hospital across the street, and is the proud mother of 4 children. So we welcome her today. We also welcome her colleague, Dr. Firehiwot Workneh from Ethiopia, who's an assistant professor of public health and director of the training division at the Addis Continental Institute of Public Health. She holds a Bachelor of Science in Medical Laboratory Technology and a Bachelor of Arts in Business Administration and Information Systems, both from Jima University. She earned her Master's of Public Health in Monitoring and Evaluation of Health Programs from Mekelle University in 2015 and completed her PhD in Public Health at Haramaya University in 2023. Dr. Workneh has over a decade of experience leading and managing short-term and longitudinal research focused on maternal, neonatal, and child health, as well as early childhood development. Her work centers on implementation research and capacity building with a strong commitment to generating evidence that informs public health practice and improves long-term maternal and child health outcomes in low and middle-income countries. So we will welcome them both up for their presentation here this evening. Please hold your questions till the end, and after the presentation, we will have a panel with Q&A both from the live audience as well as from our Zoom audience. For those on Zoom, feel free at any time to put your questions in the chat, and we will make sure they get asked at the end. And so without further ado, I welcome Dr. Lee and Dr. Firehiwot Workneh up here to give their talk. Thank you.
Thank you for the introduction. I hope you all can see me. Yeah. Today we're here to talk about our study, which focused on the child development studies. we kind of collaborate. When I say we, I'm representing my institute, which is the Addis Continental Institute of Public Health. So we have been collaborating with CC for almost a decade. So we have been working on like this strong collaboration to advance like maternal and child health. So we are going to tell you a few things about like what we have studied, starting from the pregnancy cohort until the child development studies. So just to start, I will go through a burden of suboptimal child development. So as you can see, like the globally around 250 million children do not reach their full child developmental potentials by the age 5. So this is like a study from 2016, which is a bit old, but as you can see that this prevalence of children who are at risk of not achieving their developmental milestone is kind of highly concentrated in low and middle income countries. I don't know if you can see the legend here, but like the orange one, like the orange color that you see in Africa or in the specifically in the sub-Saharan Africa shows like there is like greater than 60% of the children under 5 age, they do not meet like their full developmental potential. And this could be due to multiple factors, which includes like undernutrition, recurrent infections, or as an umbrella factor, we can also think about the, or like mention the poverty, like the infrastructure and others like within this specific regions. So as a result of this multiple like risk factors, like a greater proportion of the children in this region do not meet their developmental potentials. So as we see, like which critical periods specifically matter for a child or development or brain development. So we see like the first 1,000 days, which starts from like conception to a child's second birthday as a critical window, which we call like 1,000 days or the first 1,000 days. So this is where most rapid and active period of brain development happens in the human life, not just in the childhood, but also in the human life. So during this period, so there's like a brain forms more than 1 million of neural connection per second. And like this is like what shapes like the brain development and like the function for a longer term. So it's not just for the childhood period, but also this connection that are formed during this window determine the brain function in the long run as well. So as you can see, like even though like the life lived would be kind of short, it's like 24 months. So when we see like the brain development, so at birth, so children will have like 25% of their adult brain. So as you go from birth to the first year, so it reaches about 70%, like, and by age 2 or by age of 24 months, so the brain reaches almost like 85% of its adult size. So you can see like most of the brain developments are happening or occurring within this 1,000 period. And this is like the foundation that established the different domains of development, such as language, cognition, emotional regulation. So this is where like all these developments are happening or established. So the 1,000 period, as you can see, is a very critical period in terms of child development outcomes. So when we see like the different exposures, so the big roles or the key factors that significantly play a role in terms of child development outcomes are like the nutrition exposure and the inflammation. So as our presentation is focusing on like this early exposures and the effect on brain development. So the first is we can talk about the nutrition. So during like pregnancy or like in the early life exposure, so there's a high demand for micronutrients and also for macronutrients, so which is like both like the nutrients and also the calorie and the energy. So there's a high demand because of the growing fetus within the mother. So nutrition is optimizing nutrition during this 1,000 period is very essential for optimal brain development and again for fetal growth. So there are like specifically key nutrients that are required like during this early life, which includes like iron, folic acid, the iodine, and also the omega-3 fatty acids. So it's not just limited to this, but these are kind of the key nutrients that are essential for metabolic pathways and that kind of supports brain growth and differentiation. So like optimizing or fulfilling this micronutrient and macronutrient requirements during this 1,000 days period, like it helps to prevent like cognitive and neurodevelopmental impairments for the child. So the second factor that affects development is like the inflammation or the infection. So infections that happen or occur during pregnancy, it significantly affects brain development through different mechanisms. It could be a direct or an indirect mechanism, but it significantly affects child development, specifically like in low-income countries where the setup is relatively like poor, like in terms of infrastructure and again, like in terms of human capacity. So most of the infections are not like being treated. So there is a missed chance of like screening and treating this infection. So if we kind of optimize and screen and treat infections during this pregnancy or during the early life exposure, again, it kind of significantly helps us in preventing neurodevelopmental impairments among children. So like we are going to focus more about this nutrition and infection interventions or risk factors because these are kind of significant factors that affect like child development. Like more than like 80% of the risk factors comes from this nutrition and infection. So like going a bit deeper into some of the key micronutrients that are required for neural growth or like child development are the first is like iron, which is a very essential nutrient for fetal brain development. And so it kind of supports neuronal growth, myelination, and neurotransmitter synthesis. So iron is very key. As you can see like on the graph on the right side. So uh, as we go through the pregnancy, the requirement for iron is a bit different. So like as we go from the first trimester to the third, like the requirement kind of increases and it reaches like a peak on the third trimester. But like for different reasons, there is like a iron deficiency among pregnant women like in low-income countries such as Ethiopia because of like the different infections that prevent like iron absorption, and again like this because of like the deficiency in terms of supplementation for iron. So there is a deficit, especially like in this third trimester where it's like required most. So when we see how this affects us, so this deficit of iron in the third trimester is like associated with hypomyelination, deficits in recognition and memory, and also it kind of slows neural processing speed during the infancy period. So iron is a key or like one of the key nutrients that's required for kind of brain development, but for different reasons, there's like a shortage of iron during pregnancy, where mothers do not get like this required or sufficient amount of iron, and this again linked with poor developmental outcomes. So the other key micronutrient is like iodine. Iodine, as we all know, plays a critical role during this sensitive period of early human brain development and growth. So iodine is essential for the production of thyroid hormones that affect neural development, myelination as well. So as you can see, like on the right side of the graph, so iodine, it helps like for thyroid hormones, and you can see like how thyroid hormone kind of guides brain development throughout like the early life exposure and also until like the postnatal period as well until 6 months. So, and there is like a lot of evidences that confirms like timing and severity of iodine deficiency predicts long-term neurologic impairments, but there's kind of a limited data on like how moderate deficiency of iodine can affect this neurologic impairments. So again, like as we are focusing more on nutrition and infection, so the second component or the second major modifiable risk factor is inflammation. So maternal infections, as I've said during LMICs, are like usually do not get like treated during pregnancy for different reasons. So and like this limited access to screening and treatment, like for it could be for UTI, STIs, or for RTIs, can result in for developmental outcomes, I've said like, and this is related with lower IQ even at 10 years, not just until like 5 years, but also it goes up to the toddler period and the adulthood period. So this inflammation, the untreated infections that predisposes that increases kind of inflammation in the early life are associated again with poor developmental outcomes. So when we see like how this early life exposure, like this undernutrition and infection can synergistically affect developmental outcomes, so we see like maternal undernutrition is one. So when we see like the prevalence of maternal undernutrition, specifically in our study setup, is like close to 40% of the mothers are undernourished during pregnancy, and like it's kind of a cause for again maternal infection. So there are different mechanisms where maternal undernutrition causes like maternal infection, and again the same is true for maternal infection. So there are different mechanisms, which includes like reduced dietary intake, malabsorption, or increased nutrition losses. So this also causes maternal undernutrition. So this kind of a cyclic pattern where we have when we have maternal undernutrition, so it's a risk factor for the infection, and the same is true for the infection. And like this synergistically can cause a lot of conditions, as you can see here. So we can take like anemia as one example. So in Ethiopia, a third of pregnant women are like anemic, and anemia is kind of a severe public health issue. So which can be caused by the undernutrition and also with the infection. So there are also not limited to this, but there are also other conditions that happens as a result of this undernutrition and infection during the early life exposure. So when we see what is caused by these two modifiable major risk factors, so there's like a poor birth outcome. So it could be like low birth weight, preterm birth, or like the SG or small for gestational age. And like when we see like the effect of this on child development outcomes, so these babies that are like SJ, preterm, or low birth weight, they have like poor child developmental outcomes. And when we see there is like the risk of having these poor developmental outcomes, that includes neurodevelopmental delays, poor school readiness, and like reduced long-term outcome is like more than 4 times higher among these babies when compared with those that have like a positive birth outcomes. So we see like how significant this undernutrition and infection are in terms of determining child developmental outcomes. So when we see like now with that, we know like what is caused in terms of developmental outcomes by this nutrition and infection. So what can we do in order to reduce that? So we have seen that like most of the brain development happens in the late and early, in the late fetal and early neonatal period. So we have seen that there are key requirements for nutrition, and if we optimize like providing that, or if we kind of provide proper nutrition during this early life, so it's like it has a high impact on improving the brain health and development. So not only like limited to the nutrition, but also if we kind of screen and treat like maternal infections during the antenatal care period or during this early life exposure period, so it will like improve the health outcomes of the baby and the mother as well. But what can be done? So there are different strategies out there that with strong evidence that it works, but like not like one intervention or strategy that worked in like in one setup might not work in another setup, because there is not like this one size fits all intervention thing, because we have to prioritize and like see which specific interventions are actually are if going to make us like efficient and effective in our specific context. So we have to select from the alternatives and prioritize what's going to work best for the specific setups. So once we prioritize and select and implement these interventions, so we're just improving maternal and child health. Along with that, we are also improving good child development outcomes. So this is like the key takeaway from this slide is like we have to know like which specific interventions could work in the specific setups. So the one thing that we consider as a critical gap in the prenatal care is like if we can provide like optimal care in this early life time period, like which is in the prenatal care, then that gives us like a high chance of reducing this developmental impairments. But like usually in low income setups, like the care that is provided during the antenatal period is like suboptimal, because like there is often lack of integration. So because like there is different problems are addressed differently, not like there's no kind of addressing multiple exposures at the same time. So now that like we are advocating for 8 ANC contacts in Ethiopia, we used to like kind of advocate for 4, but with a change in the WHO guideline, we are now advocating for 8 contacts. But what matters is not just only the contact that the mother would have, but the quality of care that's provided during this antenatal care period. if we are not like treating undernutrition, or if we are not like screening and like treating for infection, so the ANC count by itself is not going to change much of an outcome. So understanding this prenatal exposure is essential during this antenatal care period or during the prenatal care period to improve like birth outcomes and again long-term child growth and development. So like improving ECD or early childhood development requires attention to this prenatal health and fetal development. And we need like to optimize the care that's being provided during the prenatal care period. So now we'll dive in a bit about what we have done as in our study. So one of our like the parent study or the pregnancy cohort study is the ENNAT study. So ENNAT stands for Enhancing Nutrition and Antenatal Infection Treatment for Maternal and Child Health. So within ENNAT, so by understanding what we have described in the background, so we aimed to determine the impact of a package of this WHO recommended antenatal care interventions to optimize maternal nutrition and infection on birth outcomes, specifically in the Amhara region of Ethiopia. So our primary outcome for that study was birth weight and birth lengths, which were like measured immediately after birth. And we had like a number of secondary outcomes for that, which includes like this low birth weight, preterm, SG, anemia, stillbirth, and we had like kind of a lot of secondary outcomes. This is just some. So, and that is like the parent study, which is a pregnancy cohort study. So knowing like, as I've talked about like the different alternatives and in terms of like the interventions that we need to prioritize and select. So our interventions were like community-centered designs. Initially, we had brainstormed on what can work best in our study setup. So we did not just decide, but we kind of brainstormed within the team and then like convened experts from the Ministry of Health, from the regional health bureaus, from societies, and again, different NGOs that work within this specific area. So we kind of planned with them to see what are like specifically the priorities of the ministry and also to understand what approach has worked among the different teams. So once we prioritize and we select our study interventions, so we went to the community to see like whether like this proposed interventions are kind of acceptable and feasible in that specific study setup. So we conducted a formative study where we used like iterative designs. So we tested and refined the proposed interventions with community. So we engaged like a lot of groups, which includes like local healthcare providers and leaders, and also like religious leaders, community leaders, and also other key community members whose influence, whose decision like makes influences. So we kind of used iterative designs. So once we know like this is acceptable and like feasible to be implemented in that specific study setup, we again conducted piloting and testing like to make just more of a refinement. And then we scaled it up to be implemented in our study setup. So we benefited a lot from implementing this complete community-centered designs. For study sites, as I've said, like our study was conducted in Amhara region, but if there's anyone who doesn't know where Ethiopia is located, we are on the eastern parts of Africa. So we had a total population of around 129 million based on the 2023 estimate. And from Ethiopia, our study was on the northern part in Amhara region, where there's around 23 million population. And like in this specific study area, like 80% of the population is rural agrarian and dependent on subsistence farming. So the pictures at the bottom would help you to see like how rural the study sites were. So why Amhara is like, because by the time we kind of were proposing this study, this specific region had like a higher maternal mortality, neonatal and also infant mortality rates. So within the Amhara region, we selected two zones, which is the West Gojam and South Gondar zones. And within these zones, we had like these 12 rural health centers. So the one picture on the right shows like one of the study health centers. So for participants, so for this pregnancy cohort, we recruited pregnant women coming to the selected study health centers for their ANC, and we assessed them for eligibility and enrolled them. So basically, the inclusion criteria were like being less than 24 weeks of gestation, having a viable fetus, and also like living within 2 hours walking distance from the study health center. So those who do not fulfill these criteria were like excluded or not enrolled. Again, this is like a picture from our health centers. So for the study design, the NAT study was a 2x2 factorial randomized control trial where we had 2 levels of randomization of this. So the first is like cluster level randomization where we randomize the 12 rural health centers into 2, which is either to implement the nutrition intervention or like to stay on the routine care. So we had 6 nutrition interventions and 6 routine health centers. And the second level was like individual level randomization, where we randomized pregnant women coming to these 12 health centers into 2, either to receive the infection management intervention or to stay on the routine arm. So in total, we had 4 arms in this study. One is like a combined arm where it's comprised of mothers who received both the intervention. And we had this 2 arms of mothers who received either the nutrition or the infection package. And the fourth or the control is a routine arm. This like mostly of mothers who did not receive any of the study interventions. Again, just to give you a highlight of what we kind of implemented as an intervention package, because most of our results are going to be related with this. So for the nutrition interventions or for the nutrition package, we had 4 components. The first is the nutritional counseling component. It's basically to address adequate weight gain and there are like misperception, including this religious fasting and also this food restrictions. So the nutritional counseling, we kind of learned a lot during the formative assessment on the restriction, the sharing, and the fasting. So in order to address that, we came up with this nutritional counseling video and also other materials to help like intensify counseling during the ANC contacts. The second component is the iodized salt. So before like providing this iodized salt, we went to the specific study site. As I have said, like iodine is like among the key micronutrients that determines child developmental outcomes. So we kind of assessed access and availability of this adequately iodized salt in the study area. So based on the sample that we collected, like from the market, from the households, and also from different like available shops, we learned that like availability of adequately iodized salt was limited. So we kind of provided like this bottle of salt monthly for a household consumption, because culturally, like in Ethiopia, when specifically in that area, so when food is prepared, it's not like it's like for a whole family, not specifically for a pregnant woman. So we provided this bottle of salt for household consumption. The third component was like the iron folic acid. So iron folate is provided by the health system for every pregnant woman in Ethiopia, but when we see like adherence to IFA was very low because of different factors. So one is because of the side effect, and the second is because of this big baby perception. So we kind of intensified again the nutritional counseling to address these side effects, and also like we kind of counseled the mothers on the benefits. So all these 3 components were like given for all the mothers who came to the routine health centers. I mean, like, and not study mothers who came or who visited like this nutritional centers. But the fourth, which is the balanced energy protein supplementation, this is like more of a targeted intervention, which was given specifically for undernourished pregnant women. So we used MWAC as a cutoff, like having a MWAC of less than 23 centimeter was used as a cutoff to receive this balanced energy protein supplement. Again, one thing that we learned from the community center design is like when we like were doing the formative, so we learned that there is a high preference for a vegan product because of the religious fasting. So we provided a micronutrient fortified corn soya blend that was locally produced. So these are like the 4 interventions, the 4 components of the nutrition interventions. And again, this balanced energy protein supplementation was like given for a daily consumption for pregnant women only. So the other major intervention that we had was the infection management intervention. Again, we had 3 components here. We have like screening and treatment basically for UTIs, like asymptomatic bacteriuria, for STI and RTIs, like we screened the mothers for gonorrhea, chlamydia, bacterial vaginosis, and trichomoniasis. And again, like in addition to that, we kind of focused and done like more activity on Geo elementis because deworming is provided for all pregnant women, again, by the health system. But when we see like there was like a gap within the supply chain, which we kind of strengthened. And what we added like for this Geo elementis is like we had this screening and testing for stool examination 4 weeks after the mothers were provided this presumptive deworming. One is to see if there's like a reinfection. The second is to see like if the kind of the deworming medication covered all the elements. So we had this screening and testing of the stool examination. So basically, like in Ethiopia, because of the infrastructure and the capacity, so these infections are done like the screening for this is done like symptomatically, where the mother would have to come and like report the symptom that she had for the healthcare provider, and it's based on a set algorithm that they'll get this treatment. But like there's a confusion that most of this STI, RTI symptoms are confused with pregnancy symptoms. So care seeking specifically for this is very limited. So we kind of screened everyone within the infection arm for this UTI and STIs. So this is basically what we have intervened or what implemented as intervention package for the NAT study. And the second is like the LIDGE study, which is the longitudinal infant development and growth follow-up study, which is like here we followed offsprings of the mothers who were enrolled in the NAT study. So again, the main aim here was like to examine the role of the prenatal interventions we implemented in the NAT on early infant exposure, so on the long-term neurodevelopmental trajectories of a child. So our primary outcome for LIDGE was the visual evoked potential or the electroencephalography. And again, same as enough, we had a number of secondary outcomes, which includes like brain MRI volumes, the Bailey behavioral assessment, eye tracking, and HIND. So these are, again, some of the secondary outcomes that we had. So this is like a summary of what we have done. So the early exposure like determines child developmental outcome. So within the NNAT or the pregnancy interventions, so we kind of provided both macro and micronutrient supplementation. So the macronutrient supplementation came from the balanced energy protein that we provided, which has like a high calorie and energy. And the micronutrient supplementation is like, one is like the BEP is fortified with micronutrients, and the second is with the AFA and also with the iodine that we provided. So providing this optimal nutrition intervention or implementing this optimal intervention help us improve like nutrition for metabolic demands during pregnancy. And again, we kind of try to control for infection by implementing this screening and treatment for deworming, UTI, STI, and so again, this kind of decreased the inflammation. In combined, so this was like the improved nutrition and decreased inflammation, improved fetal brain growth and development. So this is the hypothesis behind the LIDGE study. So that once we improve brain growth and development, we can have a productive and happy baby, as you can see. So this is like one of our study participants actually. The NAT in the LIDGE study is very richly characterized pregnancy child cohort. So as you can see within this diagram, so it depicts like the study visits and the different measures that happen within the cohort. So for NAT, the primary outcome was like this birth weight and birth length, but for LIDGE we had the VEP or the neurodevelopment as primary outcome. So we kind of have implemented different measures of development within the LIDGE study, starting from the MRI in a subset on the first 12 months visit. And again, like it continued until 24 months where we kind of had done like the EEG and other behavioral assessments. So this is like kind of the follow-up visit that we had within this pregnancy child cohort study. So now we'll dive into the child development assessment. So when we see like domains of child development, so child development, as we all know, is like a process which children grow, learn, and mature from birth through adolescence. And like the ECD, as we have discussed, like is a very critical period for a child's life because it's kind of where like the foundation is laid for future learning, behavior, and also skill and health. So when we are talking about domains of child development, we are not specifically mentioning what, but it's kind of interconnected. As you can see, we have four major domains. The first is the cognitive domains. It's physically, it's like thinking, learning, and like being able to solve problems. And we have the physical domain, where it's basically physical growth and overall health, which includes like both fine and gross motor developments. And we have the emotional. It's basically the emotional refers to like how children experience and regulate their feelings. And again, we have the social development, which involves relationship and interaction with the community within their babies. So these are like kind of interconnected domains. So when we talk about one, we are also referring the other domain. So because it's like interconnected and encompasses all the four domains. So how do we measure like this child development? So there are different modalities and ways that would help us to measure this child development and see like whether like our proposed hypothesis or intervention worked or not. So basically there are three ways. So the first is brain structure. So it basically helps us to see or understand the physical brain development. It's basically seeing the anatomy. And there are different ways to do this or to study this brain structure. One is the MRI. We have CT scan and also we have an ultrasound. So the second is like the brain function. So, and like this is basically assessing the neurophysiological activity, which helps to examine brain activity, connectivity, and how the brain kind of responds to a stimuli. So here we have EEG and FNIR, so we can see like whether like there is a response for a stimuli or where we can study like the different brain activities. And the third one is like the behavioral or developmental assessment. This is more of like observational assessment. We have a lot of different tools that's kind of validated in different setup and worked well. So this is just to give you an example of the Bailey and the GSED. So like this brain structure and the brain function are kind of advanced imaging, neuroimaging technologies that are very sensitive and objective, whereas like the behavioral developments are more of like kind of observational. So together, like if we can implement this, like all three ways of measuring child development, it will give us like a comprehensive picture of how the development within the cohort is going. So the first is like the hyperfine. So we use like this hyperfine low field MRI machine for our study to see like the different regions of the brain and like to see like the anatomy. So we use like this low field where there's no radiation. And again, we kind of use different sequences to visualize the brain tissues. So we are a member of the Unity Consortium. So this hyperfine machine was provided to us through this Unity Consortium, which is like kind of a Gates Foundation consortium. So there are like different African countries that are part of this Unity Consortium that aims like kind of to improve access to MRI and also to advance like child development studies through more of measuring the brain structure rather than just implementing neurobehavioral assessments. So since we have used like low fields, I just want to just bring the comparison between the high field and the low field. So for the low field, it has like a weaker magnetic field. And like in terms of cost and size, again, it's like smaller in size and like the cost is also minimal when compared with the high field. And there is no need for magnetic shielding. And again, it's kind of enables like point of care imaging, especially the hyperfine enabled like this point of care imaging. So there's like a lower resolution and signal to noise ratio. The high field is like in opposite to this, where like there is like a strong magnetic field, which actually enables like a higher resolution. But like in terms of cost, and this requires like infrastructures that are like very specialized. It's very larger in size, and the cost is also higher. So considering all this and like and being part of the Unity Consortium, we use the low field MRI for our study. The second is the EEG. So EEG is a safe, or electroencephalography is a safe and non-invasive technique which helps to record again electrical activity within the brain, and like it helps to see how the brain responds to a given stimuli. So EEG helps to understand like the different like neural functions, connectivity, and how again the brain network mature over time as we go like within the age of the babies. So It's again highly precise, and also it's feasible for infants because it can be well tolerated, and again due to the portability, it was like very feasible specifically for our study. So we used the InnoBio32 system for the LEG study to see like the brain activity. So it has like different anatomy or different components. So the first is the electrodes, where we had both wet or dry electrodes. And there's like this electrode cap that holds this electrodes and keeps them like in contact with the head so that it can read like the brain activity. And again, we have this amplifier that amplifies neural signals and converts to digital format. Then the last one is we had like these two computers. The first is like to show or to display the stimuli, and the second is like it collects digitalized EEG data and it displays kind of a waveforms in real time. So these are like the components of the EEG machine that we used. Again, like we kind of benefited a lot from conducting formative studies. So again, like this advanced neuro technologies are highly like kind of new, not only in rural areas, but also if you go to the urban areas, these are kind of new, especially to be used for research among healthy children. Because like if you think of this resource constrained areas, like these are like not available even for not clinical purposes, but since we are going to use it for a study purpose, so we went back to the community and like assessed whether like it's feasible for a mother to give us her baby like to do the EEG, or like if they are okay with the MRI scanning, and so because these are like healthy babies, not sick babies. So we kind of within the formative study, we assessed whether like this proposed advanced neuroimaging technologies are acceptable within the community. And we conducted like in-depth interviews among 40 with different groups. So we included mothers, fathers, community members, and healthcare providers, such as like a pediatrician, nurses, radiological technologists, and also we included radiologists as well, to understand like what they think of the feasibility in terms of acceptability by the community. So the key learning here, like from conducting the formative study for LEG, is like MRI and EEG were viewed as acceptable methods for assessing child development. And again, like we learned a lot about the importance of doing a community sensitization. So, and again, when we do the sensitization, it shouldn't be just like by the study members. Rather, we have to include like local healthcare providers and like community members as well. So, and the other key learning, which we have not included here, is like the role of the fathers in the consent process. Because like for the pregnancy study, so we had a consent of the mothers to participate in the study. Now that like she's consenting for her baby, so we learned that the importance of having the consent of the mothers as well, like to for the baby to be a part of the study. So these were like the key learnings, and like based on like the learnings from the formative, we kind of tailored like our community sensitization material. So we had two videos separately for EEG and for MRI. So one thing that I want to mention is like when we were doing the in-depth interviews, so we asked the mothers and like the community members, even the healthcare providers, and what they think about the EEG and the MRI. But since this is kind of new for them, they haven't like been exposed to any of this. So it was like kind of very tricky. So because they were responding like short, no, no, no. So we came up with this video. So we showed them. So they were interviewed like before and after of after exposure to the introductive videos, and it kind of helped a lot in terms of like understanding what they think about these technologies. So the other thing that we used as part of the behavioral development, now that we have seen like the EEG and MRI, the third component that we usually use for measuring child development is this behavioral assessment. And for that, we used like the Bailey scale of infant development. So this is kind of the gold standard to assess child development, and it's play-based age-specific task where like the study nurses had to play with the child to assess the development. So one thing like for the Bailey that I would like to mention here is like we kind of adapted. We did not just use the Bailey, but we have made some adaptation like because it requires when you use like different tools that are validated elsewhere. So it requires kind of careful consideration for cultural, linguistic, and again, resource-related factors. So this is just an example of what we have adapted for Bailey. So the first here you can see is like the snake. So where babies need to match like similarities. But like snakes are kind of bad lucks and like they're not kind of liked by the community. So we didn't want like the mothers to see their kids like match these snakes. So rather we changed it to like a white happy goat so that can be like easy for them to match. And the other is like the second is you can see like it's just a feather just to see which one the baby stink will, is heavy. So the other thing that you can see on the top is not kind of common and babies do not know that. So again, we changed it with a cultural coffee pot, which you can find like in every household in Ethiopia. So this is kind of some of the examples of the modification that we have made. And we have like yeah, like how we have done the daily assessment. Our study nurses were trained and standardized. First, the study nurse shows like the baby how to do it, and like the baby like to do this. For a second time, I yeah, just keep in it's moving. Oh. Yeah, so next we'll proceed to the results. So just this is our concept flow diagram. So I will not go through the pregnancy cohort. So, but I'll just focus on the age follow-up study. So we had around like 463 babies which that were recruited from the previous NAT study. So we had babies like making the group from the different arms. So we had like babies enrolled from the combined arm, and again like babies of mothers who received either of the interventions, like either the the nutrition or the infection, and also we had like babies from the control arm. So we had around 463 at the 12-month enrollment, but we ended up having around 423 for the 24 months because there were like a few of lost to follow-up babies. So just one slide summary of the pregnancy trial or the NAT study. As you can see, like the primary outcomes for this pregnancy cohort were like birth weight and length. So if you can see like the bar that we have here is like the orange one is for the enhanced nutrition package, and the purple one on the right side is like for the EIMP, and the gray bar shows like the control arm. So we did not actually have a significant mean difference between the control and the intervention arms across both interventions. Both for the nutrition and the non-nutrition, we didn't see much difference in terms of birth weight among the different babies. And again, the same is true for the infection, where we did not have seen like much of a significant difference in weight. So we'll focus more on the LIDGE. So for LIDGE, so first we can see like the randomization balance. So we try to see whether like the maternal baseline characteristics are balanced between the nutrition and the routine arm. As you can see, like the mean age in both, like the arms were like around 26 years. And again, we have the same kind of gestational age at enrollment, which is like 15 weeks. But when we see like the socioeconomic characteristics, so the nutritional arm had like lower socioeconomic mothers, like within the nutrition arm had like lower socioeconomic status in terms of like educational status, occupation, and again, access to tap water is like lower for the nutrition arm rather than the control. And again, like in terms of like this maternal nutrition status, like more of the women in the nutrition arm are like undernourished when compared with the routine arm. But in terms of infection arms, they were balanced. And just to see the coverage of the not study interventions among like the babies that we recruited for LIDGE. So the iodized salt was like provided in an average of 4 times. And we have also like this balanced energy protein supplementation that was also given specifically for the nutrition arm. But when we see like the days of IFA consumption or the adherence of iron folic acid, which was like provided across like both study arms, so we see like supplement adherence or like IFA adherence was higher among the nutrition arm. But like as we are like providing or implementing this intervention, the supplement distribution and like the different components of the study were affected or hampered by the civil unrest that were happening in that specific area. And also we had like the effect of the COVID-19 pandemic. So there was like relatively low adherence to food supplements and also to the iron folic acid supplementation in our study arm. So when we see like again the coverage of the infection arm, we see like the deworming is like the one thing that was provided across the arms. We see like a high rates of presumptive deworming in the infection arm because of the package as was like, and again there's relatively higher prevalence of stool or ova of parasite for the infection arm, which is mainly because like we have done the screening testing for this specific arm only. So these graphs show like the longitudinal growth of a child from birth to 2 years by nutrition arm. Again, like the orange one shows the nutrition arm and the gray line shows like the routine care. So as you can see, as birth like weight for age Z score were like similar across the study arms, which is around like minus 0.8. But by the age of 2 years old, so we see like a greater decline in like weight for age Z score among those children in the nutrition arm. And again, for links, so we see like the links for age at birth was also similar. There was no significant difference between the routine and the nutrition arm. But as we see, like after 15 months, so there's a lower trajectory decline in links for age Z scores among the nutrition arm when compared with the control arm. So when we see what predicts like the 24 months links, so we see that first is the being like receiving the prenatal combined interventions, both nutrition and infection. And again, in addition, like receiving the nutrition intervention only and like having a maternal height of more than 145 centimeter positively predicted like length at 24 months of age, whereas like being SJ negatively predicted like 24 months lengths.
Thank you, Marie. So Inat in LIDGE is Free's baby. She kind of gave birth to this entire program and project. She has 3 children of her own, but this is her 4th and 5th because of both trials. So very excited. I know we only have 10 minutes left, but this is the revealing of the results, right? You put in years and years. It's like 6 years of work to design this trial, and Free has described so well how much the formative work was critical, I think, in doing any global health work, designing the trial to meet the needs of the local population, to answer the questions that are important to them, interventions that are important, and outcomes that are important. And for us, brain development as a pediatrician is super important. So now we're going to talk about the MRI. This is like super exciting. The first time MRI was actually introduced into Ethiopia for research. And it was a low field, super novel, like low field portable MRI machine that was developed in actually at Mass General. They use it in the neuro ICU. So it's pretty cool. So these are our MRI images. We were able to scan 63 kids to bring them from the rural field site into the district hospital. We wanted to introduce the MRI into the district hospital because we didn't want it only used for research. We wanted it also used clinically. Somehow Free and the team was able to do this amidst COVID and a civil war. She got 63 kids. We don't have a huge sample size, but for MRI studies, this is pretty reasonable. 30 per arm is actually quite good. So we have 63 kids, about half in our intervention arm and half in not. All of the images went directly into the cloud, into this flywheel platform. And then we're able to use this segmentation software called Minimorph. So what it does is Minimorph then segments the brain into its different regional sections. So you can see here, you've got I'll first start with the cerebral cortex, dark purple here. Okay, that's the brain tissue. Students, everyone here. Then you've got the light purple here. This is your cerebral spinal fluid. You've got your ventricles, your extraaxial fluid, and then you've got your deep gray matter structures here, which include thalamus, globus pallidus, putamen. And so what you can see though is that this is much more granular, it's more grainy, it's much more lower resolution than a regular MRI. I think Free showed some of those structures. So there's a lot of kind of technology being developed to use AI software to actually have these images be as good as a high-res MR. But it does quite well in invalidation studies. So these methods are evolving, and Sean Dione and Viren Desa are actually at Brown and helped develop some of this technology. So these are the preliminary effects. So this is a big reveal day, and these are actually some of the positive results we have that we're really excited about. So among the infants that had MRI, they were randomized. This was a randomized trial. So half were in the arm at the very right that received both interventions, both nutrition and infection control. So those that we think had optimal nutrition, optimal iron, optimum iodine status, balanced energy protein supplementation, and optimal deworming. As you know, the other infection rates were kind of low. So lower exposure to inflammation. And so what we were seeing is that in the arm that received both of those intervention packages compared to those that received neither, that we are seeing subsignal of higher total brain tissue volume at 1 year of age. So even though it was a prenatal intervention, even at 1 year of age, we are seeing small effect size, about 7 mils, but higher total brain tissue volume, relative total brain tissue volume. And then we're also seeing lower total cerebral spinal fluid, total CSF. So it's showing that the brain is actually developing in a more healthy way. It's maturing better. It's reflecting by more robust tissue growth. It's filling the brain more, which means less atrophy and less CSF. So these are very kind of exciting preliminary findings. None of this is published yet. We're all like sharing with you very early findings. The other kind of very important finding is that Free has mentioned fetal growth restriction being small for gestational age. That's being a small birth size relative for your gestational age, less than the 10th percentile. And so fetal growth restriction can result in long-term impacts on the baby in terms of higher rates of stunting, higher rates of infectious disease, higher rates of cognitive impairment. And so what we are seeing is that these babies, this is one of the first MRI studies in sub-Saharan Africa that has followed for growth-restricted babies until 1 year of age. And so we're showing that unfortunately, even at 1 year, there is not much catch-up, that the total brain volume and as well some of the deep gray structures, which are kind of really important for cognition and executive function, are still much smaller at 1 year of age. So next, we'll move on to the EEG, which is a measure of brain activity. So we conducted the EEG later. So the MRI was about 1 year. The EEG was at 24 months. And so EEG is kind of a measure of all the brain activity or waves. There's many different frequencies of waves. It's like a radio where you've got many different, levels of sound and frequencies of sound. And what we do is we do frequency analysis where we kind of try to separate the sounds of different frequencies or the brain waves at different frequencies. So you've got your beta waves, which are associated with alertness or concentration and thinking, your alpha waves, which are associated with meditation, creativity, and relaxation. And there's actually the most data on alpha waves. Alpha waves have been very strongly associated with later childhood cognition. So that's actually our primary outcome for this trial because of the kind of existing prior data. And then theta waves, which are more associated with kind of dreaming and visualization. But we examined the power, the strength of each of those kind of channels or bands of EEG brainwaves. And so what we did find here, Teresa Chin did most of this analysis, one of our postdocs, is that unfortunately there was no effect of nutrition intervention on EEG power of any of the bands, unfortunately. So no impact of interventions, nutrition intervention on the power of the brain wave activities of all of these bands. And similarly, there was no effect of the intervention arm either. But we are seeing some kind of signal that if you break down the alpha wave that I said that is associated with more long-term cognition into what we call oscillatory alpha as the more regular kind of oscillations, that there is some signal where we are getting some enhanced neural maturation in the nutrition arm. So those that got the food supplement versus not. This is, early analysis, but we are at least, excited about that. And then the Bailey. So that Bailey is what most people are familiar with. It's the kind of behavioral, cognitive, motor kind of assessments. Unfortunately, there was no difference in Bailey scores between arms, either the nutrition versus non-nutrition arm or the infection versus non-nutrition arm. So how do we interpret these somewhat mixed findings? I think we've discussed, very beautifully discussed how we can assess the brain in terms of structure and anatomy, to then function, which is electrophysiology, what kind of signals are being sent, to then behavior, which is how does the child actually performing on assessment. So we are seeing some kind of subtle changes in brain structure, increased brain tissue volume, less CSF, so more mature brain. It's filling up the brain, the space in the brain more. And maybe some early functional signatures of some alterations in the EEG that are subtle. Like the typical metrics, there was no difference. We had to kind of look at these oscillatory alpha waves. So some signal that we might be seeing some differences in brain activity, but then by the time we get to the behavior that's typical Bailey, we're not seeing too much of a difference. Some of it may be related to the sensitivity of the Bailey. We had to do some adaptations. It's a coarse metric of child development. It's a global metric, not specific for these kind of hypotheses that we had, that specifically iron and iodine would improve myelination in neurons and actually improve the speed of brain processing. We still have a lot of analysis that's being done with that, related to visual evoked potentials, which is the primary outcome, as well as eye tracking, which several of the students here, Eden, Salam, and others are working on now to see how we can look at visual attention with that. And then the other kind of big factor is that this was all prenatal intervention, but there's a lot that happens after birth, postnatally, in terms of, as Free mentioned, kind of poverty, food, things that we know also that the nutrition arm was actually worse off. They had less education, less waged work. So the postnatal factors may be having more of an influence. So we had another study that we were going to potentially present, but we could also stop for questions.
Yeah, why don't we pause now?
Yeah.
And so we have some time for questions.
Yeah, that sounds good. Well, maybe just a sneak peek for those that are really interested in child development. This team here and Free, and Kalkidan were the first to actually adapt the WHO global scale for early child development for Ethiopia and Amharic, to adapt it and kind of conduct a large cross-sectional study in also in Bardar, Ethiopia. So that is actually a very exciting study. If there's students or trainees that want to get involved with that, I'll just highlight that. And then the other is just in terms of, as part of the study, we did also cross-sectional MRIs in 400 kids from 6 months to 6 years. And so there's also a lot of opportunities for that. But I think in terms of speaking to the postnatal influence, what we are seeing is that postnatally, maternal education is very positively correlated with brain volumes and structure, and maternal stress is adversely or negatively associated. So showing that we can actually make a difference if we're able to make changes in the environment that the child is in. So I think we had, more in kind of mixed results. I think we can kind of discuss maybe with Firehiwot.
Thank you so much.
Great, thanks.
Dr. Lee, Dr. Workneh, please come join me up here on our panel. We need a microphone for people online to hear us.
In the ceiling, but we could have another.
If we don't need it,
But if you want to project your voice a little bit, you can use this. Sure.
Perfect. Well, thank you, both of you, for presenting the results of your research. I know from experience how much work and effort and how many years of your life get poured into trials like these, and especially when you're doing large trials in a low resource setting, in the middle of a pandemic, in the middle of a war. The challenges and the stress and the work is exponentially higher than it is for running trials like these here in the United States. So it's really impressive that you even got to the finish line. And that's something that's really important to mention as well, is that I think most people never do get to the finish line on trials like these in low resource settings. So congratulations to both of you for that. I'm going to open it up now to questions from the audience. So if anyone has questions, please just raise your hand and we'll have you ask them. And I have questions as well, but I want to really give all of you a chance to ask your questions. Similarly, for those of you who are joining us online, if you want to put your questions in the chat right now, our wonderful staff, Megan, will ask them as well. So, any questions? Dr. Abid.
First question, yeah. So this is excellent, very exciting. So I would like to know whether your experimental arm, that the infection and the nutrition, that stopped like at birth or delivery, or you followed the child also after their postnatal development, like until infancy or some stage?
Yeah, so thank you for your question. So the interventions were like until delivery, like one pregnancy cord kind of ended at the 1 month after postnatal period, but like most of like all of the interventions was the infection and the nutrition were provided until delivery. So we just followed like the offspring of those mothers, but we did not have any other interventions.
So you just followed up another 24 months?
Yeah, the babies.
Okay. Babies, yeah. Thank you.
Yes, Dr. Barry.
Really incredible study. I'm just amazed at what you did. And you taught me so much about this new MRI technology. It's so exciting what we could potentially do with it. One question I had was going back to your results, the unbalanced study arms, which one might imagine were not in your favor the way that they fell out. Did you go back and reanalyze controlling for some of those maternal weight and maternal socioeconomic status education level?
Yes, we did.
Not sure.
But you can hear me? Okay. Yes, we did. Actually, we adjusted for that in the primary analysis per consort. Yeah. Yeah. But it was a very unfortunately imbalanced by many factors that were, adversely affecting our outcomes. I think maternal education was much lower. The prevalence of waged work, income generation was lower, land ownership was lower, access to running water, which is a huge one. And so it's not only confounding for, our primary outcome was, which is birth weight and birth length, but obviously the postnatal impacts on child development, I think, probably outweighed the prenatal. So, that's always been a huge debate in child development literature. It's like these critical windows of development, right? And, the concept that if you have an early hit, that some of these kind of impacts on the child's brain is permanent. So there's been this long 1,000 days, movement that, optimizing early is going to help the most. But we also had pretty severe kind of postnatal disadvantage in our intervention arm, which was hard to adjust out, unfortunately.
Yeah, and in some ways, it is the downside of doing a cluster randomized trial such as this, because, even though you had thousands of patients, at the end of the day, you had six sites, and those sites are in different areas with probably very different populations and resources and experiences that, in addition to what you measured, there's probably all sorts of other experiences you didn't measure that are different between those sites as well.
Yeah, and you've hit the nail on the head because I mean, exactly at the beginning, pre-COVID. So to mention like getting this trial completed, this was all kind of designed. We were asked by the Gates Foundation to design the trial. We had a year of co-design with our partners because we really wanted it to be to fit in the Ethiopian Ministry of Health's kind of priorities, the questions they wanted to answer. But it was designed completely before COVID. And then when we were about to get approval, like from the FDA, it was like right during COVID, and they were actually going to cancel the entire trial. And so we originally had, I think, 40 clusters. It was originally a 40 cluster trial, which was 2020. So it's almost like you have 20 clusters intervention, 20 clusters, which is adequately powered. But because of the severe kind of restrictions on resources or defunding, it went from a 40 cluster trial to 6. And so what one trialist said to me after, when we were so disappointed that it was a completely null trial for the primary outcome, they were like, yeah, you spent so much effort. And it was like, it was a six person versus 6-person trial. And I was like, I know. But that's the problem. Like when you do trials, like you have to justify why it needs to be cluster randomized. And I'll let Free speak to this, but our partners are very much like you cannot individually randomize women to receive a nutritional supplement or not, because that's not appropriate for a community. All the Ethiopians know this. You can't say that like a neighbor can't get a food supplement. It has to be at the village level. So it was, we sacrificed the scientific rigor for what was right to do. And it was how we can implement and deliver good health services during a very difficult time. But it definitely was not an optimal, like rigorous scientific design.
And I want to talk to that point, if both of you could talk a little bit, because I think this is incredibly important. In science, we know that people suppress negative results all the time. Negative studies go unpublished. And, even if they are published, the presentations people give at conferences, the things people talk about at cocktail parties are always the positive studies, not the negative studies. But science can't exist without the negative studies. And we need to learn from the negative studies as much as we learn from the positive studies. So I want to thank you guys for being open about your study results, which were largely negative. But I'm really curious, for all the, budding global health researchers in the room, what the experience of having a negative study was like for you, and then what lessons you learned both personally and also scientifically for how you would do this differently in the future.
Yeah, so definitely this is not what we anticipated, like with because like we went far like in terms of like the ethics of like providing the supplement like for a selected group and like not like providing it for the others, even though we know that they are malnourished. So we kind of learned that like it's not like how you only implement it. There are also different factors which we have not control for, such as the environmental factors, which we did not take into account. So one is like the number of clusters. So if we are about like going to do it again, maybe we'll like increase the number of clusters and increase like the power of the study to detect like this minimal differences and show that the intervention actually works. So now like people might assume like whether we intervene or not, so we're not going to make any difference. But it's just the power, and like there are also different factors which we have not accounted for. And if we were like to do it again, maybe we'll just consider those, and that's kind of a major learning.
Yeah, I mean, I think agree on all of that. I think that, funding and resources are major challenges. So it's hard to
The funding is real. You might have the most high quality study in mind, but then you don't have the money to carry it out.
Yeah.
Especially in global health.
Yeah. But I completely agree on the null results. I mean, this is, as someone for I think my Bangladesh trial was my 5th child. That was a 10,000 pregnancy randomized controlled trial. They did have 40 clusters. We randomized community health workers to provide a screening and treatment intervention for vaginal infections and urinary tract infections. We did have 40 clusters and we were adequately powered, but that was completely null. And it was interesting because JAMA had asked us, they wanted to publish it before we had the results. And once we had the null results, they were like, oh, maybe we're not interested anymore. This was a year later, but I think there is definitely bias against it. And it's critical, actually, that the negative results need to be published. It's heartbreaking. It's truthfully completely heartbreaking. Now that we've had 2, but at the same time for this trial, we did actually reduce stillbirths by 70%, right? And you have to think that what goes into WHO guidelines are actually the findings from these types of trials, right? You learn from what works, what doesn't work, and you have to know what doesn't work to know what you want to really think about scaling globally, because you're not going to tell people, well, you should screen everyone for urinary tract infections with very expensive cultures. It cost us like $20 to do each individual urine culture because there's no refrigeration. You've got to kind of get it to the lab within 24 hours if you have a fancy boric acid container tube, which is super expensive. It's very difficult to implement this. And the prevalence of infections was so low, it was about 4% with UTI, and there's no population level impact. So even though it's recommended in the US and by ACOG to screen and treat for urinary tract infections, and everyone has it in the US, it's not on WHO guidelines because there actually is no evidence that it works or that it's cost effective. So you need to have the null trial results that are going in to inform those guidelines that WHO is making about what works and what doesn't work. And then also, I think really important for this is like, right, you can totally have null results and you can feel like super sad that you spent all your life's effort to make this change, but at least you're generating evidence that's going to help inform what does and doesn't work for other people. And so gathering more data. So I would say definitely getting cost effectiveness data. That's something we did a little bit of, but maybe not so well, but people always think about, and ministries want to know, WHO wants to know what was the cost effectiveness of that. And that's something that I think more and more is becoming more and more important with the resources and resource limitations that we have now. So that's something.
Looks like we have a question from the internet.
We do. They say impressive studies and important findings. Congrats to the team. I wonder if compliance with the intervention is potentially a modifier. Possibly those with the higher adherence may show greater effect.
Yeah, so like actually like we had like in terms of adherence, we had like for the balanced energy protein supplementation and also for the iron folic acid, but adherence to the supplements was like, yeah, it's a modifier, but it was like affected significantly by different factors, which is like by culture and also by like specifically I would like to talk about the sharing. So like the mothers that were malnourished, so we provided them with this balanced energy protein supplementation, but sharing was like a common culture that like if the mother is like having that BP supplementation and if anyone comes while that, so that's kind of culture like to share that. So that kind of affected the adherence, but we have seen like among those who adhered, the results were like much better.
Another important lesson. So there are so many things about this study that you guys did really well and you did right for a global health project. And one of them was the intensive community consultation you did before you even started the study. And I love the idea of the community co-design. Can you just talk about some of the things that you changed from your original plan based on those focus groups and interviews with community members?
Yeah, maybe like I would mention one. So the first is like this balanced energy protein supplementation is one of the major things that we changed. So initially that we are like in contact with this NutriSet company to provide this BP supplementation, which is non-vegan. So once we go to the community, we try to understand whether this is acceptable or not. This is like a strict Orthodox community where like pregnant women are expected to fast. So I would say like more than 200 days of a year are like fasting within this strict Orthodox community. So we wanted to provide this balanced rich protein supplementation, which is non-vegan. But when we go and like kind of assess whether it's acceptable or not, it was not totally acceptable because everybody kind of wanted like a vegan product, which can be consumed during the fasting season as well. So again, taking this into the co-designing with the ministry and other stakeholders. So we brought these different alternatives, like whether we should like go with a NutriSet or we go like with other products. But there was like a preference for a locally produced product, which is like kind of makes it easier for scale up. So that's what we changed. So we went like for a micronutrient fortified corn soya blend rather than like providing this plant-based sap, which is like mostly peanut based lipid and like non-vegan. So that's one thing that we changed. Basically, I would say like the major one that we changed.
The food restriction too.
Yeah. Yeah, the other is like the big baby perception. So when we kind of assert again the community, so one of the clauses for not adhering to the iron folic acid supplementation, so there's like this big baby perception. So if your mother like consumes like more diversified and increases the frequency of food that she takes in during pregnancy, so she might gain weight and the baby might also gain some weight. So that is like the big baby perception. If the baby is gaining more weight, so that would complicate the labor process because like some of the health facilities are far, so a mother might not reach there. Like, so just to minimize that complications, they usually restrict like their intakes. So they kind of take limited food portions, and also there are also different food groups. Those are restricted to be consumed during pregnancy. So again, we try to include this and address this with the nutritional counseling material that we had.
Other questions? Yeah, in the back there.
Yeah, I was a bit curious if whether it was considered if the mothers were first-time mothers and if that had outcomes of the study in the follow-up.
Yeah, just repeat.
Oh, like whether like if we recruited only like first-time mothers or not, and if it had like impact on the study. So we did not restrict like for being like a first mother or not. So we kind of recruited anyone, like any pregnant women coming to this 12 study health facilities and have like kind of fulfilled out like eligibility criteria like for inclusion, but there's no like specific differences like by being like a first mother or like not. And specifically, I'm not sure if we have like specific differences between like this premium or not. We didn't like much see a difference by being like this a first-time mother or not. So, but there was no like exclusion or inclusion. We did not favor anyone. We just like included like all those like who fulfilled the inclusion criteria, irrespective of whether it's for the first time or not.
Yeah, I have one question. Thank you so much for the incredible talk. I was wondering if there was any look into the impact specifically of the social adversity on birth outcomes within the cohort, and if there were any particular forms of adversity that you think have a bigger impact on
We have not specifically looked at it yet, but one of our faculty, Sarah Jensen, is looking at the role of maternal stress on birth outcomes, both birth size, as well as preterm birth, and was, interested in also potentially looking at, because this was right in the middle of the war, the impacts of that as well. And actually, Molly has looked at heat stress, climate stress and heat stress in birth outcomes. Maybe she can comment on that. Very interesting findings.
Yeah, we did find that with increased heat during pregnancy, babies were born slightly earlier and with smaller head circumferences. So that's something that we're going to keep looking into, because Ethiopia is an area of the world that's particularly impacted by climate change and will continue to be more so.
We have time for like one more question. Anybody else have a question? Nothing in the internet? All right, then I'll ask the last question. So if I got it right, it also seemed like you embedded sort of a ethical study within your larger trial where you were trying to understand the ethics of introducing these new technologies and how they would be perceived in that setting, as well as some questions about consent by fathers and so forth. And so I was curious, because that's also not something you always see, sort of a focus, not just on research ethics, but on actually like studying research ethics within these global health contexts. And so I was wondering if you could comment a little bit on that, what generated the idea for that sub-study and how you experienced it.
Free led that, and she published on it.
Yeah, that was like the formative study that we had, like the major aim for that was like to see whether it's acceptable or not. But so we had like this MRI machine in the regional capital, which is like a bit far from where the study sites are located. So we have to transport the mothers, like that's what we proposed. Like we'll just transport them from the study health centers to the regional hospital, and like they may have like to spend a night there, because like the MRIs, the children will sleep more like at night, so we can use that, because we have not been using like any sedation, like that was a proposed activity. So we'll just let them sleep naturally, and we take the MRI scan during that time. So, and we understood like mostly they like kind of sleep at night. So just to optimize using that, we propose like whether like if we can kind of give them a transport then, have them stay like in the regional capital for a day, but like that kind of raised like issues with the community, because like a mother should not like have a night away from the family, especially when the husbands are not there. So that was kind of what we learned. So for some, actually, they agreed like to be transported with other like mothers within the study, but again, there are some where we transported like the whole family to the regional capital. So yeah, it's just like one thing that we learned from the community. Like we kind of learned a lot from the formative studies, because like we co-designed with the community. So that kind of led most of the activities, and yeah.
All right. Well, thank you both for presenting on your work today and for the work that you've done. And just for the audience, I want to remind everyone that our last event of the year will be our Global Health and Equity Symposium, which will be on April 28th. So at the end of April, it'll be a fantastic event where we have a Naveen Salem from Adizia presenting on some of their work around childhood malnutrition, especially in light of the upheaval in the United States and with global funding for nutrition. And we will also have presentations by students on their research and a poster session. So it'll be a really fantastic event, and highly encourage all of you to come and encourage all of your friends to come as well. So hope to see you guys there.